Welcome to the second presentation of the ASRM Grand Rounds webinar series in reproductive endocrinology and infertility. These twice-monthly webinars are designed to address topics in the ABOG Learning Guide in reproductive endocrinology and infertility. Today's presentation will be given by Dr. James Liu, Professor of Reproductive Biology and Obstetrics and Gynecology at the Case Western Reserve University School of Medicine and the University Hospitals of Case Medical Center. Dr. Liu is an internationally recognized expert in the field of reproductive medicine. He has extensive experience in the conduct of clinical trials, and the title of his talk today is Clinical Pharmacology of Hormones. I will now turn the microphone over to Mr. Jeff Hayes, our education specialist, who will review the details of today's presentation and introduce Dr. Liu.
Thank you so much, Dr. LaBarbera. Good morning, everyone. I'm Jeffrey Hayes, the ASRM education specialist and moderator for this webinar. Before we begin the webinar, I'd like to go over a few housekeeping items. First, to make sure we can cover all the content in the allotted time, everyone's line except the speakers will be muted. We will devote about 15 minutes at the end of the presentation to questions. Please feel free to type a question in the chat window at any time. I will then read as many selected questions as possible to the presenter during the allotted questions and answer time. If for some reason you need to step away from the presentation, please sign out and then sign back in upon your return. After the webinar is done, please do not forget to return to ASRM eLearn to take the post-test and complete the survey for your CME credit. You must complete the post-test question successfully and complete the survey to receive credit and be able to print off your certificate. Our speaker today is Dr. James Liu. We are very excited for his talk today, so I will now turn things, click on here, we're going to turn things over to Dr. Liu.
Thank you very much, Andy and Jeff. I'm a little bit under the weather, so my voice might break a little bit, and I apologize. So let me go over today's learning objectives. I'm a clinician by background, so I'm going to focus more on the clinical aspects rather than all of the molecular biology that you may have been presented to with the first grand round. And we really want to define some of the things that go on when we give drugs and hormones that affect the reproductive system. So we're going to look at some of the aspects of absorption, excretion, distribution, and biotransformation and bioavailability of drugs and hormones, and what are governing some of the things that transfer these compounds across the various structures in the body into the cell, and what is its expected target tissue. We're also going to look at the different delivery systems, primarily for steroids. We'll touch a little bit on glycoprotein hormones, but I don't have time to really go into any detail regarding glycoprotein hormones or how they're produced or availability. So this part of the learning objectives we will not have time to cover. Just some disclosures. I do consult for a variety of companies, primarily in the reproductive area, and I do conduct clinical trials and have a clinical trials unit. So the main goal of hormone and its receptors really is to communicate between a needed function, and the body does it in a variety of ways. And so we'll call these hormones or signaling molecules, and their ability to be able to perceive these signals, specifically these receptors. So their receptors are geared then to certain types of signaling hormones. We'll go over some of the ways that this communication occurs, talk about primarily the steroid hormones and their intracellular receptors. There are some gases that function as signaling molecules like nitric oxide. We won't cover neuropeptides. We'll touch a little bit on GnRH, which is a peptide hormone, and some of the analogs, and we won't cover the prostaglandin type mechanisms. We'll also look at some surface protein cell receptors, G protein coupled receptors, and how the steroid receptors work, primarily looking at some of the new features that allow us to have selective estrogen receptor modulators and progesterone receptor modulators, the so-called tissue-specific coactivator complexes. And obviously, after the receptor binding, etc., there's all this downstream signaling within the cell. We'll go over some aspects of the signaling pathway just as a brief review, and then we'll really talk about the meat of the presentation, which is really how these drugs are applied and how they work in the system in the body. So to begin with, there are 4 principal ways of communicating between cells. Obviously, the most known to us is the endocrine pathway. So an example would be the GnRH neurons in the hypothalamus communicating with the pituitary via a portal circulation. For example, GnRH telling the pituitary to release LH. And this is a very, very well-established system. And then there are obviously paracrines where hormones diffuse into the extracellular fluid to affect neighboring cells. An example would be leptin receptors being activated and then communicating with GnRH neurons. This was at the level of the hypothalamus. There is also a mechanism called autocrine, more recently established, where hormones bind to its receptors on its own cell and modulate its same cell function. That happens with neurotransmitters to some extent. And juxtacrine, where cells really express growth factors extracellular that provide anchors to the cell, and then others have growth hormone receptors. So this would be an example of communication during implantation, where the embryo is communicating with the endometrium. Now, a variety of ligands and receptor pairs are known, and just to name a few, acetylcholine, obviously a well-known neurotransmitter, binds directly to cell membrane. Thyroid and vitamin D and steroid receptors actually are all related. For those of you who don't know, vitamin D is really a steroid hormone, and it binds to specific vitamin D receptors. And they have a very same configuration and motif on the cell. And they work in very similar fashion, and they are conserved. And then obviously all downstream signaling then results either activation in cyclic AMP, changes in calcium intracellular levels through perhaps a phosphatidylinositol pathway or diacylglycerol pathway. One of the things that we need to be cognizant of, and I have to keep reminding our residents and fellows, is that when you administer pharmacology to a patient, specifically, let's say a reproductive hormone, you really are disrupting the normal endocrine feedback mechanisms, whether it's a pathological feedback mechanism or a physiologic mechanism. So I picked one that doesn't have anything to do with specifically with the ovary or the gonads. For example, a sucking stimulus stimulates the hypothalamus and posterior pituitary to secrete oxytocin into the bloodstream, which then targets the smooth muscle in the breast tissue and milk release. So we can give an oxytocin injection and avoid this entire suckling reflex. And certainly one can administer intranasal oxytocin in this manner and get milk letdown to some extent. There are a variety of cell surface protein receptors. Probably one that you're familiar with is the FSH receptor. It acts principally via tetrameric G proteins. And characteristic of these types of receptors is a serpentine receptor configuration in the cell membrane, and it uses a GTP pathway. In its resting state, there is a GTP alpha with a beta gamma attached to it. And when activation occurs, the GTP alpha separates the beta gamma unit, and then downstream signaling occurs. In this case, it could be protein kinase A which then produces physiologic effects. And then this system then returns to its resting state with GTPase activity, converting GTP to GDP, and it then reassociates. What about calcium? There are a variety of mechanisms that regulate intracellular calcium, and this can be a very effective form of signaling. Much of perhaps there are three major ways that calcium can change in flux in the cell. One is the fact that the calcium concentration in the interstitial fluid is about 12,000 times that of what's in the cytoplasm. So there's a normal gradient that's directed inwardly, or it can be inwardly directed through an electrical gradient. There are also ATP pumps that regulate calcium channels and a variety of calcium channels, and also a sodium-calcium exchange mechanism. So these are all ways that calcium can be activated. And calcium in the cell usually is bound to endoplasmic reticulum and is released from those sites. Now, the tendency for calcium to come into the cell, then, to be more specific, through these calcium channels, these are usually ligand-gated in the case of GnRH receptor, voltage-gated or stretch channels. And so the downstream effects are activation of inositol triphosphate, which could be a second messenger, and GnRH receptor is a good example of that. In some, the calcium channels increase from the estrogen receptor, and membranes cause a more sustained response. All of us dread this chicken wire structure because it means that we have to rememorize the steroid pathway before every test. Let me kind of give you some simplified ways of trying to remember all this stuff so that when we talk about this, you have a basic understanding, because the concepts are probably more important than the structures. Almost all steroids that are produced in the body can be derived from a cholesterol cytoskeleton, which is a 27-carbon moiety. And characteristic of this is the position of the double bond between the A and B ring. When the double bond is in the B ring, this is considered a delta 5 configuration. And when the double bond is in the A ring, it's considered a delta 4 configuration. And cholesterol essentially gets cleaved, and the key sort of limiting path is the side chain cleavage enzyme, which is a cytochrome P450 mediated step. Thereafter, the steroid pathway evolves into, depending on the tissue types, adrenal or gonads, either into a 21-carbon mineralocorticoid pathway, which is straight down here, or a cortisol pathway, which produces cortisol or cortisone. And if we go across, again, the delta 5 pathway, we get successive cleaving of the carbons to a lower number of carbons. So in this case, a 21-carbon molecule, which arose initially from cholesterol, is cleaved to a 19-carbon, and that's the 1720 lyase, which is a key enzyme step in the gonads. And then subsequently, it is then converted to various constituents in the androgen pathway, from dehydroepiandrosterone to androstenedione to testosterone. And then a final cleavage step is the aromatization step to estradiol, which is somewhat unique in the ovary and does not occur to any great extent in the testes. So this probably is an easier way to remember sort of the pathways as opposed to just memorizing all the structures. And we'll talk principally regarding these steroids in a minute when we talk about delivery systems. Now, the signaling from these hydrophobic hormones are very common in terms of their receptors, and this has been conserved evolutionarily. And based on DNA sequencing, there are probably over 70 members in this receptor family, but we haven't really identified all the ligands for this. Probably only have 40 ligands identified. So commonalities among this is the DNA binding domain, the ligand binding domain at the end here, and the variability in the amino terminal end, depending on the type of receptors we're talking about, ER alpha, ER beta, glucocorticoid receptors, PR beta, PR alpha, or PRB, PRA, and androgen receptors, mineralocorticoid receptors. And we could probably add vitamin D receptors in here and thyroid receptors in here. Generally, once binding occurs, a number of steps occur, and I'll diagrammatically show you in the next one, but let's just list all the things that do happen. The lipid-soluble hormones bind to the receptors inside the cell, and it can be by active transport or by diffusion. There are also now identified steroid receptors on the cell membrane, and they work via a different mechanism. We won't have time to go over that in detail, but just be aware that this is being identified in a number of steroids, mainly for estrogen and progesterone. We know that these three types of steroid hormones, glucocorticoid, estrogen, and progesterone, are bound to the heat shock protein in the cytoplasm in the absence of any steroid binding. And with steroid binding, the heat shock protein then drifts off and it uncovers a DNA binding domain, which then allows the steroid receptor complex to bind to the DNA binding domain, the hormone responsive element, and then downstream transcription can occur. Now, this is a very simplistic model that has changed over the years, but we now know that there are actually much more complexity than this as diagrams. And so here are the steps in terms of the steroid diffusing into the cytoplasm, the uncovering of the heat shock protein, steroid receptor complex with the hormone binding to the hormone responsive element. And then we now can identify a variety of co-regulators or transcription factors. And these co-regulators are different in different tissues. So depending upon the type of tissue, breast, endometrium, or brain, the types of co-regulators and co-activators are different, and therefore, when they bind to this steroid receptor hormone complex, the amount of transcription and efficiency of transcription varies. And so the agonistic and antagonistic biological properties then become manifest, and it differs depending on the distortion of the steroid hormone receptor complex and the ability of these co-activators and co-regulators to bind to this steroid hormone receptor complex. So this is the basis for our explanation for selective estrogen receptor modulators and progesterone receptor modulators. So let's go back to a more clinical issue of how do we get steroids into the body. I think all of us are very comfortable with taking pills. We'll talk about some of the limitations of giving steroids orally. Many of us are familiar with the vaginal route, and I'll give you some fine points on differences in vaginal drug delivery since this is my area of expertise. Many of you may not be familiar, but there are actually estradiol and testosterone implants that have been available. It is used in many animal work. Steroids can also be administered percutaneously with either microneedle injections, sublingually because it bypasses the portohepatic circulation, buccally, intranasally, so you can have inhaled testosterone, which is one of the experimental routes people are looking at. And all of us, I think, are familiar with transdermal routes, and we have a variety of them, patches, estrogen spray mists, gels, and lotions. And obviously we can inject steroids which have 100% absorption, either IM, sub-Q, or IV. So let's talk a little bit about the oral route. So here's a diagram of what happens. Let's say this is estradiol that you're giving orally. So 100% of the drug makes it into the stomach. It's absorbed into the small intestine. And at branch point 1, the enterocytes lining the small intestine transport the drug into the enterocyte and into the portal circulation. And this is mediated by P-glycoprotein active transport, and there is a little bit of CYP3A4 that does do some metabolism and breakdown of the product, but very little of it. And about 30% reaches the liver. Then at the level of the liver, this is number 2, the hepatocytes of the liver, 30% of this then reaches the liver, and there's again active transport in the enterocyte by P-glycoprotein, and a really high level of CYP3A4. And in the case of estradiol, a large amount of the estradiol is converted to estrone. So when you measure estradiol levels, they are markedly decreased, but the estrone levels are usually twofold higher, because not only is there conversion, but there is a removal of the H moiety in the estradiol to make it an estrone. And this is an ongoing process with many of our drugs, and a variety of metabolism occurs, and we have to understand this when we administer microdosed progesterone, for example, and a lot of people are taking DHEA orally. So this affects downstream what really is absorbed and what the interconversion occurs, and what really the bloodstream actually sees and what the target tissue sees. Let's look at the vaginal drug delivery in women. And in this particular model, about 30 women with a hysterectomy had the uterus and the vaginal collar removed. And they put radioactive, in this case, tritiated progesterone into the vaginal collar and looked at the level of radioactive progesterone in the effluent when they perfused the uterus. And you can see that within 1 hour of the gel being placed into the vaginal collar, they were seeing significant levels of radioactive progesterone, which declines by about 3 hours. They also extracted endometrium from these samples at various times up to 12 hours. And you can see that there is a concentration of progesterone that begins to increase, and it doesn't really peak until about 5 hours after the application of the gel into the vaginal collar. And what they've been able to identify is that in the uterine bed, specifically higher up in the vagina, there is a lymphatic and vascular circulation that delivers steroids preferentially into the uterine area. And this is the principle of using vaginal progesterone for preterm labor and for luteal phase support. But if you put like estradiol on the outside, more towards the outer lower 1/3 of the vagina, you do not get the systemic absorption. So the location of where you put the gel is important in terms of how much is seen by the systemic circulation. This is a key point. Now, dermatologists love putting things on the skin, and obviously glucocorticoids on the skin is one of the principal things they do to decrease inflammation for a variety of skin disorders. And these studies will probably never be repeated, but this is from the Maybach group, done in 1969, where they essentially used carbon label 14, which is an isotope and applied a variety of steroids to the skin and looked at the rate of absorption in percent of dose per hour, and they looked at this for about a half an hour, and surprisingly, hydrocortisone and some of its analogs were very low in penetration. The progesterone, estradiol, and testosterone were intermediate, and look at this, DHEA, the androgens were actually better absorbed than the hydrocortisone. So the rate of absorption is much more rapid for DHEA, and this is sort of doesn't have a clear explanation for why there are such differences. Suffice it to say, this is a 21-carbon hydrophilic, and this is hydrophobic, and this is a 17 and 19 carbon hydrophilic. So what about total absorption? Again, the same pattern. This is percent of dose absorbed over a time frame of the study. And it shows that, again, hydrocortisone was very low, and DHEA and being the highest, and then the testosterone and estradiol kind of being intermediate. So how do we translate this to what we're doing with women? And occasionally women are put on transdermal testosterone, albeit at a much lower dose than in men. The first delivery system using a patch or occlusion was different from the patches we currently use today, and was made by SIBA. And essentially it consisted of an occluding plastic backing layer, a drug reservoir containing estradiol in alcohol, ethanol, a rate-controlling membrane adhesive, and then the purpose was to drive this steroid across a gradient through the multiple layers of the skin, which consist of the stratum corneum, stratum granulosum, the dermis, and the capillary. And systemic delivery was achieved, and the doses that we see today, the 0.05 milligrams per day and the 0.1 milligram, for example, were the initial doses that were marketed by this relatively new delivery system. Improvements in the system have been made, and now we have essentially the estradiol in the adhesive glue matrix, and the matrices are much better. The adhesions are much better. You can actually go into a hot tub with a estradiol patch, and it won't float off depending on the type of patch, whether it's generic or name brand. It still has the backing layer, but it's able to achieve good adhesion over a period of 3 to 4 days. And the improvements in the delivery concentrations, etc., allowed decreases in the size of the patch. And so this is our modern patch with the adhesive matrix and then driving the steroid through the skin. And this is used, there was a testosterone patch as well, so other steroids can be used using the system very, very efficiently. So what are some things to know about some basics of drug delivery kinetics? So the amount of drug that crosses the skin, we call the flux, is really governed by a very simple fixed first law of diffusion. Essentially, it depends on, and what you need to know is the surface area which the patch is. So the larger the patch, the larger the amount of flux, and the concentration of the drug, C. And obviously, every individual will have a different Kp, which is the permeability coefficient, because the skin may be thicker in some people and not in others. So one can obviously then increase the delivery by increasing the surface area of the drug. And so if you were to cut a 0.1 milligram estradiol patch in half, assuming it doesn't have a reservoir, and it's a matrix adhesive, you will cut the delivery by half. And this is the principle in which the size of the patch determines the amount of delivery. And so this is a very important way to kind of customize your patient's patches if you decide that she needs a dose that isn't available. Now, the gel delivery systems are a little bit more refined than this. Instead of using a backing layer, there is no occlusion, and the steroid is really very alcohol soluble, so they'll use an alcohol-based gel, much like our alcohol-based sanitizers. In fact, you could probably put estradiol in a sanitizer. I wouldn't recommend it, but that could be a suitable base. And in this case, the rate-controlling membrane is the stratum corneum of the skin. And functionally, the reservoir and diffusion barrier is really the stratum granulosum and the dermis. And so that determines the controlled release over a period of time. It's certainly not as sustained as the patch, as you'll see when you look at the kinetics, but it's certainly maybe less obtrusive for some folks who don't like to have something stuck to their skin and more used to putting on lotions or gels for skin dryness. So some fine points about cuteness drug delivery. When you apply it to the skin, usually in an alcohol solution, it penetrates within about 10 minutes. And it can then begin to see some systemic estradiol in the systemic circulation over several hours. And about 10% of this dose passes through this barrier, and it's eliminated in about 72 hours. If you occlude it with something like saran wrap or a plastic, it increases the absorption tenfold, as you'll see, and it does not alter the absorption rate. So what about blood flow to the skin? I mean, geez, you can put your patch or your gel on different sites in the abdomen and your buttocks and your thigh or arm. We did this in a pilot study, and we were really not able to show any differences, whether it was on the trunk or the extremities. And when we looked at the effectiveness of various doses of estradiol-containing gel, what we found was you got a pretty decent clinical response in terms of vasomotor reduction by about 4 weeks, with a plateau at about 8 weeks. And this is replicating the patch studies and also some of the oral studies in terms of clinical response. So be patient. Tell your patient it takes about 8 weeks to have reduction in hot flashes. What about the first pass circulation? And when we look at the gels versus a patch, in this case Chimera, what you find is you don't have an exaggeration of the estradiol-estrone ratio because the liver has not had the first attempt to metabolize the estradiol. And so there's almost a 1-to-1 ratio of the estradiol to the estrone. And this is similar to what happens when the ovary secretes estradiol into the circulation and with the patch and with the gel. So it's quite physiologic. If we apply the gel to either a small area or the largest area, you can see that the concentrations, if you apply it to a smaller area, is more efficient. So it looks like the sweet spot is somewhere between 200 and 400 square centimeters. And what about sustained estradiol levels? So the patch gives you, and these are just multiple daily samples, gives you a very sustained, predictable level. So 50 micrograms per day gives you about a 50 picogram of estradiol. These gels have different concentrations, so you'll need to look at the concentration to get an idea of what the delivery system is. And they will vary depending on the alcohol base, whether it's Divigel, Estrogel, or some other kind of gel. But suffice it to say, there is a fairly nice sustained release. So this reservoir and rate controlling membrane using the skin rather than the matrix is quite effective. You take a shower, does it affect anything? The answer is no, it doesn't affect it. And so washing the gel off, once you've waited a suitable period of time, doesn't seem to do anything due to effects on the concentration, Cmax, or the area under the curve. So in summary, for the transdermal drug deliveries, especially the cutaneous ones, the drug is absorbed and retention occurs in the stratum corneum and granulosum, the reservoir effect, and it does readily reach the systemic circulation. It doesn't seem to be affected by where you put it on the body. Now, one of the things that I always emphasize with patients when I counsel them as to, well, do you want to take a pill or a patch or a gel, is the impact of the first pass effect by the liver. And here's an example of a liver effect. We're measuring renin substrate on the y-axis, and we're looking at premenopausal women, which have a modestly normal range of estradiol, and women that are at baseline. And here we're giving them various doses of estradiol by patch, and here we're giving them oral conjugated equine estrogen at 2 doses. And you can see that the liver effects are very marked in the oral, whereas we see very little difference in the estradiol. And you can do the same kind of studies for clotting factors and some of the other estrogen-sensitive liver proteins. And hence, there is certainly a clinical assumption that if one uses transdermal route, there will be less perturbation of the coagulation system. Also, there is also less of an impact on the HDL rise compared to the oral routes. So I apologize, my screen blanks out, but let's talk about progestins. There are 3 common progestins that we use. Natural progesterone, one that's in birth control pills, which is an old kind, norethindrone acetate, and medroxyprogesterone acetate we'll call MPA. And for some reason, my Mac doesn't transfer very well to Microsoft. I apologize for the blackout. So a variety of things happen when you take progesterones depending on the route of administration. If you take the progesterone orally, in this case, it is metabolized by 20-alpha-hydroxysteroid dehydrogenase to 20-alpha dihydroxyprogesterone. And this particular compound causes people to be sedated. And it binds to receptors that are similar to alfesin, which is an animal narcotic, anesthetic. So if you have a patient that has a little bit of insomnia, if you're going to give micronized progesterone in a menopausal lady, give it at bedtime. It will have some somnolent effects. And in fact, the initial studies that we did with high doses of micronized oral progesterone did induce sleeping as one of the side effects. The other thing that does happen is when you take it is the 5-alpha reductase, and this occurs at the breast level, and 5-alpha progesterone is a very potent stimulus of breast cells in terms of mitosis. So this could be an effect that may be unwanted at the level of the breast with progesterone. And obviously the classic pathway is the 3-alpha hydroxylation, and most of the progesterone is broken down, and then it's glucuronidated. Now, a word about medroxyprogesterone acetate. It's an old drug, and there is really not a lot of metabolic studies that were done when this drug came to market, and no one is interested in certainly fine-tuning this at this point in time. But we now know, based on more recent studies, that MPA may not be broken down by CYP3A4 during metabolism. And it appears to bind to progesterone receptors as the intact medroxyprogesterone acetate. So this may have some downstream implications at the level of the breast or some things, and it may give us an explanation for why in the Women's Health Initiative the estrogen progestin arm had a much greater increase in breast lesions as opposed to the estrogen-only arm. So the jury is still out on where MPA is in this whole scheme of things. So progestins have a very, very desired effect on the endometrium. I think all of you know that it induces secretory changes acting via progesterone receptors, which begin to appear following estrogen priming of the endometrium, and it serves to limit the growth of the endometrium. And it reduces the concentrations of the estrogen receptors, which is a very important component in terms of limiting the changes that might be associated with unopposed estrogens, such as hyperplasia or endometrial adenocarcinoma. So it probably can be viewed as an anti-estrogen in endometrial tissue, but certainly not as an anti-estrogen in breast tissue. And some very early studies using very early, and we now call primitive techniques, by Bill Gibbons, shows that that with estrogen priming at higher and higher doses of conjugate equine estrogen, that the estrogen receptor increases in the endometrium, and when you add MPA, the estrogen receptors fall relative to estrogen alone, actually to a level that at a 5 milligram per day or a 10 milligram per day dose, much lower than baseline. So in essence, MPA is quite protective, and the dose really that's required is really only about 5 milligrams per day, not the classic 10 that we choose to use clinically. So for a number of women who are on estrogen and have a uterus, they're very unhappy when they're put on progestin because it induces a variety of mood changes. And clinicians know that patients avoid it. They may not even take it as prescribed. So is there a way to kind of determine how much progestin a woman really needs? And regardless of the preparation used, I mean, how much progestin do you really need? This is a classic study, and I'm just going to summarize because we don't have time to go over these studies, by Whitehead. And what he found, looking at a variety of enzyme endpoints of progesterone action, with looking at also mitotic endpoints in the endometrium, regardless of the preparation and dosage of estrogen and progestin used, if you're giving it cyclically, the predominant proliferative endometrial effect was always associated with bleeding on or before day 10 after the addition of progestin. So if you don't give enough number of days of progestin, the woman bleeds before day 10. So if you're giving a continuous estrogen progestin in a cyclic fashion, if you're going beginning of the month estrogen progestin together, if the woman bleeds before day 10, you're probably not giving enough days of progestin, or you're not giving enough high enough dose, or she's not taking it. So after day 11 or 8, what he observed was with predominantly secretory in appearance. So this is kind of a clinical pearl of using day 10 as your marker for inadequate progestin effect. And are there differences in menopausal ladies in terms of endometrial thickness if we give them a continuous estrogen gel, which is this study, or we use different forms of progestin to oppose this estrogen effect on the endometrium, which is unwanted. So in this study, they looked at up to 12 months worth of estrogen, and they looked at the application of a levonorgestrel IUD. This is a small dose IUD, and oral progesterone given at 100 milligrams every day, continuous, or vaginal progesterone. And there was really no difference, as long as you gave it continuous combined, between local administration of a progestin, a very potent progestin, oral progesterone daily, or vaginal progesterone. So really, the effects on the endometrium is to promote atrophy. So adequate responses. So what are some suggested progestin doses required for secretory changes in estrogen-primed endometrium? And these are old studies, but basically for MPA, it's 5 to 10. So you can go down from your classic 10. Vaginal progesterone gel, and you can use, obviously, there are some new progesterone tablets, about 200 milligrams per day for gel. I don't know that we've done the study for some of the newer products. If you're giving drospirenone alone, which is not available in the US but is available in Europe, it's 45 milligrams. And for norethindrone, which is available in a continuous progestin birth control pill, 0.25 to 1 milligram, and some other progestins that are not available, dydrogesterone in the US. Here are the various doses. Now, if you don't do anything and you give transdermal estradiol or oral estradiol at standard doses, and these are probably high doses now compared to what we were using maybe a decade ago, how long does it take to get hyperplasia? And so they biopsy these folks. These are all in studies that got baseline and biopsies at 1 year or 2 years. And it shows that you get about almost a 40% rate with unopposed estrogen at 1 year, and about a 12 to 13% at 1 year with conjugate equine estrogen, and at 2 years about 30%. So you do need to use progestin. And so a variety of continuous combined regimens were done and marketed before the Women's Health Initiative. These are less in favor now, although I think some of them are still available and marketed, but not promoted. And clinicians, if a woman has a uterus, have gone to a variety of patterns of progestin. There's the sort of the cyclic regimen, which many clinicians favor. In this case, you just decide when you want to give your 12 days worth of progestin at the beginning or in the middle of the month, and you deal with the progestin-induced side effects such as mood disturbances, breast tenderness, and headaches, or you give it in the middle of the month and you bleed at the end of the month. You can certainly use continuous combined like in the Women's Health Initiative. This is less favored because this is a longer duration of progestin exposure. And there are some folks that are using long cycle every 3 months for 14 days. And there's some evidence that this is effective at preventing hyperplasia. But the studies are very small and very limited. So let me stop there. Almost finished on time, and open to questions. Go ahead, Jeff.
Thank you so much, Dr. Liu. And as Dr. Liu just said, if you have a question for him based on something you want to ask about the presentation, please type that in the chat window. I'm going to turn things over to Dr. LaBarbera, who already has some questions that he has fielded from participants. Dr. LaBarbera.
So, Dr. Liu, one of the questions that has come in has to do with variability among patients in steroid absorption and metabolism. How reliably, when you administer a particular preparation, can you predict, how a particular individual is going to absorb, metabolize, react to a particular preparation?
Yeah. Okay. Our best experience is, at least in women, is with estradiol and progesterone. So if you give it vaginally, and you put it high up in the vaginal area where the vaginal collar is, there is very little evidence that there's a huge variability in absorption. If you give it orally, for example, estradiol, and you drink alcohol, it increases the estradiol levels through the ceiling. And this was published, I believe, in the New England Journal, and we still don't have an explanation for that. If you give progesterone, micronized progesterone, and micronization is a process where you essentially have these progesterone microparticles or crystals that are formed when you spray progesterone in alcohol and let it evaporate. It increases the absorption, but it's influenced by whether you eat oily foods like Kentucky Fried Chicken with your progesterone. Absorption is better because the oils tend to enhance delivery in the gut, or you eat something that, or you take Metamucil at the same time, which is bad.
Okay, so a follow-up question came in then. Is there any necessity to develop methods to predict hormone dynamics in individuals, or is it just so standard, so uniform that you really, and I guess as you suggested, it's pretty reliable based on people's diet?
So I think that the thing about taking medications is that you want to do it at the same time of the day, and preferably, if you want more sort of consistent absorption within that individual, take it on an empty stomach. Obviously, older people take many, many pills, so there may be effects of those other pills on the one that you're taking, that you're targeting the reproductive tissues. So I think the clinical pro would be to look at the symptoms, make sure you wait for the 8 weeks before you say the vasomotor fluxus is not going down, and modify the dose, because you have to look at the time frame in which you expect a clinical response.
Great, and here's another question, a little bit different. Why do you think subcutaneous estradiol, the Rizal preparation, went off market, and what do you think about compound subcutaneous estradiol pellets?
Okay, so the pellets, I've actually put them in. They come in little cylinders, and you inject them via a very large bore needle, like a 10-gauge needle. So it hurts, and they do have to be inserted about every 3 months. The surface area and release characteristics are very similar to the patch. You do get some drop-off towards the 2.5 months in. A lot of what I call homeopathic doctors are using it, along with testosterone pellets. So, I mean, it's okay. I don't think it's something that is going to be tolerated long-term by the patient just because it's a nice 10-gauge needle.
And then why did the subcutaneous estradiol go off the market?
Don't know.
Don't know.
Okay.
Okay.
Probably because it didn't sell.
Of course. So we don't have any other questions that have come in, so I'm going to turn it back to Jeff Hayes.
Okay. All right. Well, thank you, Dr. LaBarbera. I just want to mention to everyone before we wrap things up, our next Grand Rounds webinar will be Thursday, October 1st at 6 o'clock p.m. Eastern with Dr. Richard Reindaler on the topic Contemporary Periconceptual Evaluation of Congenital Adrenal Hyperplasia. Look for an email going out probably a little bit closer to time for that one, but we will send emails out to everyone to let you know when registration happens. Also, if you're interested in CME credit for this activity, go ahead and return to ASRM eLearn to take the post-test the survey. Thank you so much to Dr. Liu for presenting today. I know you didn't feel 100% today, sir, and thank you so much. And we will have this presentation will be archived online very soon. We will send out emails to everyone once that